Get rolling here. Good afternoon, everyone. It's a pleasure to introduce one of our pediatric endocrinology faculty, Dr. Sara Watson. Sara has been a member of our division here at the University of Louisville and Norton Children's Hospital since 2014. So she is rapidly becoming one of our senior faculty members within the division, and so it's been a pleasure working with her. And some of the things that she has really shined in during her career is she has been, from a clinical standpoint, she is director of our weight and wellness program, as well as our type 2 diabetes clinical program. From a research standpoint, she has been very successful in obtaining NIH funding as, and I think it's the Kentucky Pediatric Clinical Trials Network and the Kentucky ECHO project. Trying to make sure I get all that correct. And she is, as well as the Idea States Pediatrics Network. So I need to make sure I pull that all together. And I'm a little bit backwards, but she did her pediatric training here at the University of Louisville and Norton Children's Hospital. She did her pediatric endocrinology training, as well as obtaining a master's in clinical research at IU at Riley. And then, as I mentioned, she joined us in 2014, and so she's been one of our most successful, nationally recognized faculty members. And I think the topic today fits very nicely into both her clinical work as well as her research efforts. And so it's going to be about obesity treatment in children, the longevity of impact. All right, welcome, Dr. Watson.
All right, thank you. All right, I have no disclosures. So as Dr. Winiger said, I am going to talk about weight loss, and I want to talk about the impact of weight loss on health, the treatments and the evidence for how long the treatments will actually impact weight, and then how we can apply these findings to clinical strategies. I am not going to talk about epidemiologic data of obesity. I think we all have that down. There are no color-coded maps that show how bad the epidemic is. I'm not going to go into the etiology of obesity or really go through the pathophysiology. I really want to focus on, can we really make this work? And I will tell you, there is, as a pediatrician, often limited information in the pediatric data. And when there is such limited information, we do look at the adult data. And so I have done that here, and at least half of what I'm talking about today is adult data. But I just want to throw this disclaimer out there that many of you are much more familiar with that data than I am. And so there may be things that I have missed in my review, and so please share those things. I think it's an opportunity for all of us to learn, and I'm excited to discuss this with you all today. So hopefully Dr. Winiger won't mind being on there again, but we often start these with a clinical vignette, an interesting patient or something that really made us think about doing a deeper dive in the literature. But I was actually on a Zoom call, and I was on a Zoom call about this research network that Dr. Winiger mentioned. So it's a pediatric clinical trials research network that's across the country, essentially, and there is an obesity focus group. We're working on putting together a clinical trial, and the conversation is always, well, what's the intervention going to be? And in pediatrics, it is more recently shifting towards medication, which is not something we've commonly used in the past for reasons I'll discuss. What struck me was that in this conversation, the emphasis was on using medications for the long term, which is very different than our current paradigm in peds of you maybe get a jump start with weight loss using a medication and then try and carry that forward. And so the pediatrician in me was really reluctant to give up on lifestyle modifications. So I thought I would delve into this and see what we really can accomplish with just the lifestyle. And part of the reason the pediatrician in me clings to that so much is because this is what we've been taught. So the paradigm is we have a staged approach. We start with basic lifestyle. We go to more structured lifestyle. We add some more counseling and dietary guidance to it. And then we might make it to medications, right? And where you start and how fast you move through these stages depends on the severity of obesity and the comorbidities, which is really similar to what we see in adults. There are some caveats to pediatric weight management that are a little bit different than in the adult world, and that is we have growing kids. We have kids that have brain growth going on, and we have to consider the nutrition that they need in that setting as well. So the guidance for safe weight loss in children is that if you have a kiddo 2 to 11 years old, which is generally before puberty, that you can lose about 1 pound per month safely. Not very significant from an adult perspective or from my own. If you have an adolescent, a pubertal or post-pubertal individual with severe obesity or those with comorbidities, then weight loss of up to 2 pounds per week is probably safe. A lot of times they'll focus on trying to lose 1 pound per week. But we don't have really good evidence to back this. This is mostly expert opinion. So we also have a different categorization for severe obesity because we can't base everything on a strict BMI cutoff since those change based on sex and age. And so severe, we use the percentile of the 95th, okay? So I will show you that in just a minute. But I want to mention one of the other mainstays in pediatric weight management is you're going to grow. So if you can maintain your weight at whatever this weight is, as you get taller, your BMI goes down, which is great, but it often does not have the impact that you think it will. So I wanted to just include that weight maintenance may be sufficient in mild obesity. But beyond that, we need to take more aggressive measures. So mild obesity is defined as a BMI less than the 120th percent of the 95th percentile. All that means is they put more lines on the growth chart. So this is the standard growth chart where the solid lines are, and then the dashed lines are the percentage of the 95th so that we can have better stratification of those individuals in the obese category. And I highlighted there that where the 120th percentile of the 95th percent is, so you have an idea of where that is. I wanted to just put it a little bit into context with the actual BMI percentage. So for a 10-year-old girl, you reach that mild obesity threshold at a BMI, an absolute BMI of 25. For a 12-year-old, it's 30, and for a 15-year-old, it's 35, just to see where that correlates. That works in the clinical realm, but in research, we don't use the BMI percentile, and because it isn't a good measurement over time. And so we need a reference standard that accounts for age and sex. So what has been used is the BMI Z-score or BMI standard deviation score, and that's just the distance from the mean. This is the studies that I'm going to talk about today. This is primarily how they report weight outcomes in those studies. So I just wanted to give you a frame of reference. The CDC classification for overweight based on a BMI Z-score is greater than 1.04, and obesity is greater than 1.64. It's a little different based on World Health Organization guidelines, but just as a frame of reference, I think that's good enough. Okay, I think that's all the terminology I wanted to get in there. So if we go back to the staged approach for weight management, these are the adult guidelines. And like I said, it looks very similar to what we do in pediatrics with a heavy emphasis on lifestyle therapy, but an earlier initiation of weight loss medication as an adjunct to lifestyle treatment. It doesn't become a primary therapy that you start at the same time as lifestyle until you get to the obesity stage 2. So still a lot of steps before that where lifestyle is going to be important. So I mentioned that we don't have very many medications available in pediatrics. The longest approval is actually for Xenical. It's approved for 12 years and older, but it's really expensive and it's not that well tolerated in adolescents. Something about that watery or oily stools and, abdominal pain while you're going to school is not fun. But if we're talking about long-term treatment, I think cost is a significant consideration. And $700 per month is a lot, but not as much as liraglutide. So in pediatrics, liraglutide was just approved, a Saxenda, in December. So 5 months ago. I know it was approved in like 2012 or something like that for adults for weight loss, but we just got it in 2020. It's even 12 years and older. It's now approved. And so it is very expensive. And $1,400 per month means that we really can't prescribe it because most insurance companies aren't covering it. But for a long-term treatment, that's a significant expense. The drug that gets around that is Phentermine. It's not really approved for kids, except 17 years and older, but it is really inexpensive. It's not really an option for long-term therapy, though. It's only approved for short-term use because of the cardiovascular side effects with hypertension and other things, but a consideration of an affordable medication. All right, so what I really want to answer is, can we achieve clinically meaningful weight loss with lifestyle and medications? I'm not going to talk about bariatric surgery today because that's kind of its own category and it has much more dramatic effects, but focus on our mainstay of treatments. And then also, can we maintain that weight loss over time? So there are a myriad of comorbidities from obesity, which we are all familiar with, and so I'm only going to hit on a few. And I am not going to go through an exhaustive list of the studies that have looked at this, but what I tried to do was find some representative studies that would at least give us an idea of how much impact can we expect weight loss alone to have on these comorbidities. So blood pressure is the first one I want to look at, and the particular article that I found was a meta-analysis. So we got up to almost 5,000 participants, which is really good. It was a meta-analysis of randomized controlled trials, and the interventions included calorie restriction, increased physical activity, or a combination of the two. And the follow-up ranged from 2 to 91 months, but the mean for this analysis was almost 17. We aren't really surprised, but weight loss was consistently associated with blood pressure reductions. So for every kilogram of weight loss, you lost about 1 millimeter of mercury in your systolic and diastolic blood pressure. So that's pretty good. And we could potentially have a meaningful clinical change based on that. I just want to note that there were multiple studies that used the DASH diet as part of the dietary counseling and the lifestyle modifications. When you had the DASH diet, the impact was much better. So I've pulled out the ones that did not include that as listed as part of the counseling. I actually found a really big pediatric study too that was a cohort study of 5,000 obese youth. And there was not an intervention, but they just followed with serial measurements over time and then looked at what happened to the blood pressure for the individuals who lost weight or gained weight. So we're back to the BMI Z-score, standard deviation score, and for every 0.1 reduction in that score, you got a systolic blood pressure decrease of 0.4 or diastolic of 0.26. So there was a change there. Of course, when you had an increase, it was not a proportional increase in the systolic and diastolic. It seemed much more dramatic, but all right, so cholesterol. The review ranged from, this is a review article, and it just looked at multiple studies that ranged in follow-up from 6 to 24 months. And they found that if you had a weight loss of 5%, that you got a decrease in the LDL cholesterol of about 7.7 and triglycerides decreased by about 11. You know, there's a lot of overlap in what you counsel individuals on with dietary changes, because when we try and counsel on lifestyle, we do say eat a lower carb diet, and we ask individuals to decrease the fats in their diet, and which will have an impact on this as well. And so just to note that LDL also decreases with decreased fat intake and increased fiber, and triglycerides are also going to decrease with lower carbohydrate diet and exercise. So there is some confounding on that. So in kids, we also have a positive impact on cholesterol. This particular study used the traffic light diet, physical activity, and behavior therapy. And I think most people are probably familiar with this, but essentially green foods are the good foods. They're the low fat, low carb. Yellow is kind of neutral. They're in the medium category. And then red are the high fat, high carb foods, right? So if there was a decrease in the BMI standard deviation score of 0.25, then you had an improvement in the LDL and triglycerides. However, once they corrected for the dietary interventions, there wasn't really a positive impact on the LDL cholesterol, but there was on triglycerides. So for every 0.1 decrease in the BMI standard deviation score, triglycerides went down by 2.3, which is not a big change, not a dramatic change, I should say. The diabetes prevention program is probably one of the topics that we know a lot of, everybody knows a lot about, but it followed people for a really long time. So I thought it was really important to look at just in this context. So this is the only study that I have looking at the impact on prevention of diabetes. But as we know, this looked at 3 arms: standard lifestyle recommendations plus placebo, standard lifestyle plus metformin, or intensive lifestyle. And these individuals were all overweight with a BMI of about 34 at the beginning.
This is pediatric?
This is adults. There is not a comparable pediatric study. So, unfortunately. All right, so their standard lifestyle recommendations did include increased physical activity and following the food pyramid. And then on the intensive, they were more specific with a low-fat diet, low-calorie, and encouraging moderate intensity physical activity. And they had a pretty good weight loss, the average of 2 kilograms over the first couple of years in the metformin group, 5.6 in the intensive group, and then in the placebo group, there wasn't much weight loss. But the incidence of diabetes was much lower, which is why we know this study, right? So it was 58% lower in the lifestyle group and 31% lower in the metformin group. And they also, in their analysis, determined that weight loss explained the majority of metformin's impact on the decreased risk for type 2 diabetes. So weight loss seems to be a big component in preventing that as well. We see a lot of kids with sleep apnea, so this is one that I really wanted to look at. And this is the adult study. So we had almost 1,000 participants, and then they tried to get repeat measures 4 years later, and 700 of them said, sure, I'll do another polysomnography. But the baseline BMI and the follow-up BMIs were a little lower than in a lot of these studies. So only 29 at baseline. And the obstructive sleep apnea is measured in the apnea-hypopnea index, and generally greater than 2 is considered obstructive sleep apnea in the mild category. But they did note at baseline that there were more apnea-hypopnea, higher apnea-hypopnea index in the individuals who were in the obese category than the others. And if they lost weight, their scores changed. So this graph over here shows, shows that if they lost more than 5% of their body weight to 10%, there was a change in the AHI index of somewhere between 1 and 2. And then if they lost more than 10% of their body weight, then that decreased by 25%. And the absolute weight loss was a mean of 3.1 kilograms for individuals that actually had their AHI drop from the moderate sleep apnea category down, which is a clinically significant change without a huge amount of weight loss. So I thought that was interesting. All right, so they did this study in kids, and they did a behavioral weight loss intervention in 61 obese children, not a really long follow-up, and the mean weight loss was 24 kilograms, which is huge. So I just want to note that this study was not done in the United States. It was done in New Zealand. And so, there's a very active outdoor community. And so I think it's a little different than what we may find here, but it was the best study I could find. They had a very large decrease in the BMI Z-score of 0.9, and then they did have a significant improvement in the apnea and hypopnea events as well. All right, so I'm going to summarize them here, and then we're going to come back to this. So I want to talk about interventions that have worked, and I'm going to start with focusing on dietary interventions and changes. So the Look Ahead study had about 5,000 adults with type 2 diabetes who are overweight or obese. They used dietary support and education versus a group lifestyle intervention that's modeled off of the diabetes prevention trial. So in the first year, they focused on weight loss and increasing physical activity, and then they went into maintenance over the subsequent 7 years. So a pretty long study, which is great. And this is the first one of these charts that shows what we're going to see multiple times, which is in that first year where you have that intervention, this intensive lifestyle group had a great weight reduction. And the diabetes education group didn't have as significant of a change, but as the intensive lifestyle did. But then when the primary intervention stopped, the weight loss was not sustained. So in the maintenance period, they regained a significant amount of weight. But overall, at the end of 8 years, they had still lost 4.7% from their initial weight. And of the individuals who achieved 5% weight loss in year 1, 50% had still had 5% weight loss at year 8. And individuals that had more than 10% weight loss at year 8, about 27% of them were able to maintain that. So there is hope, but only a quarter were able to maintain that 10% weight loss over 8 years. The predictors for the individuals that were able to maintain weight loss were high levels of physical activity, reduced caloric intake, and frequent monitoring of body weight. The Mediterranean diet is something that's recommended a lot, and there have been multiple studies that have looked at the impact of the Mediterranean diet alone on weight loss. And these studies were all 2-year follow-up, and the mean BMI change was 2 to 1.5%, and that was in adults. So we have a lot of different options for structured weight loss programs, and then the question is, do these have long-lasting impact? So this is a meta-analysis of weight loss maintenance from 2 to 5 years, and it only includes people that had successful weight loss in the first intervention phase, right? So this looks at very low energy diets, which are less than 800 kilocalories per day, and hypoenergetic balanced diets, which are based on 80% of resting energy expenditure. And this is the subjects consuming the very low energy diets are the circles here. They had the most significant weight loss at the beginning, and then were able to maintain more weight loss than the other groups. This is kind of all the groups together, and this is that hypoenergetic balanced diet group, which sounds really hard for to maintain. So after 5 years, 23% of them maintained their initial weight loss from the full group, which is about consistent with what we saw at the 8-year mark for the previous group too. These are the pediatric studies. There are fewer of them for sure, but one of our mainstay recommendations is to tell people not to drink sugar-sweetened beverages. So I was actually interested when I found that there was a study that looked at, let's just get people to stop drinking juice. So they enrolled adolescents who said, yes, I drink at least one sugar-containing beverage a day. Then they tried to get them to stop doing that by replacing it with something else. They even shipped bottles of non-caloric beverages to their homes to get them to drink these things, which is really interesting. So they got shipments every 2 weeks, and they got phone calls, and they followed up for 2 years and looked at the change in BMI at 2 years, and it didn't matter. So this was the absolute BMI percent change, but the change in BMI at the end of 2 years was not significant. So still not great to drink sugar-sweetened beverages, but it's not going to help us much with weight. What we do use a lot really are health consultations and education. And so this looked at young kids, 5 to 9 years of age, and they received health consultations and general pediatric practices during a 2-year period, and then the other group also got additional education on top of that. And there was a significant mean BMI Z-score change of about 0.2. Motivational interviewing has also been recommended, and so there is a study that just looked at that as a way of delivering that content for lifestyle modification. And so they kind of had the usual care versus this tailored intervention based on motivational interviewing, and it did seem to work some, but at 2 years the BMI Z-score change was still about 0.2. And there's a lot of debate in pediatrics if you need to treat the parents versus the kid. There are studies, short-term studies, that show that if you give this education to the parents alone and leave the kid out of it, the weight change is the same as if you engage the kid in a lot of these lifestyle modification programs. It makes sense. The kids aren't grocery shopping, and they don't control when they get to go to the park and things like that, right? So this was actually a family-based treatment. So it looked at the parent, at least one parent, and the kid together, a similar young age group of 7 to 12 years, and then they looked at, they had to have at least one overweight parent, and they did look at the parents' BMI as an outcome too. So they did this family-based treatment, and it included, there were 3 groups: no treatment, behavior skills maintenance, or social facilitation maintenance. I'm sorry, I should say they first gave them a family-based treatment everybody got for the first 9 months, and then they went into a maintenance phase. So this is really looking at the maintenance phase, which were one of those 3 things. And they delivered these skills for the 2 intervention groups through individual sessions with the kid and the parent, or through group sessions, and they did that weekly. And they focused on weight control, parenting skills, and also addressing barriers to following through on these interventions. When they looked at the results, they stratified this based on how much weight they lost in the intervention period. So this top line are the individuals who didn't lose as much weight in the family-based therapy portion, and then this was kind of the average weight loss, and then those who lost more weight in that initial intervention period. And then we're looking at the weight at the end of follow-up. And you can see that this weight regain is once again pretty prominent for the individuals that had the high family-based treatment response. But overall, the individuals had a BMI Z-score change of about 0.1, 0.2, or 0.3 in that high responding group. So I mentioned that the diabetes prevention program followed people for a really long time. So after they had the intensive lifestyle modification in the initial group, everybody was offered that, and they could go to these classes 4 times a year. The folks who had originally been randomized to that group were offered booster sessions to really reinforce those self-management behaviors for weight and activity. Those were the individuals that had the best response to weight loss that I showed you in that initial 2.8 year follow-up data. So then they followed them longer term. So this is at 4 years. And their main outcome for this study was, can we get them to lose 7% of their body weight? And so in the lifestyle group, in the first 4 years, 50% achieved that mark. And then in the 7% had that, 38% of them were able to maintain that. But we have longer term data for this study. It actually went out to 15 years. And so this kind of puts them stratifies by how much weight they lost initially. These are the folks that lost less than 5% of their weight, and then these are the folks that lost more than 5% of their body weight initially, and then they followed over time. So this is the metformin group, which is a much nicer line. This is the intensive lifestyle. So they have that huge drop up front, and then that regain, but still some weight loss, and then placebo. And this kind of pulls out just those 5%. So it's just a little bit easier to see. For the intensive lifestyle group, at year 2, 74% of them had lost 7% of their body weight. And then you can see how there was definitely regain, but in years 6 to 15, you still had 40% that had lost 7% of their body weight. So that's pretty good longevity. In the group that was on metformin, they stayed on metformin and then also were offered that intensive lifestyle. And so you can see that they had some folks that did a little better at the very end than at the beginning, but the weight loss was much more consistent over time in that group that had metformin, which made them recommend, like, oh, should we do this? Should we give the individuals who have that really good weight loss up front, then put them on medication so they can stay on metformin for a long time, and maybe we'll be able to maintain more weight loss. That's only a recommendation at this point. I couldn't find where anybody had done that. But the predictors of long-term weight loss were greater weight loss in the first year, and then, of course, in the intensive lifestyle modification group, if you didn't have diabetes, if there was no family history of diabetes, or an older age, that was a better predictor. In the metformin group, older age or use of metformin, and then in the placebo group, a lower baseline fasting plasma glucose. It all makes sense. So that's kind of looking at metformin. There's the longest weight loss study I could find with the GLP-1 analog was 2 years, and this is the adult data. This is the extension study of a 20-week randomized controlled trial, and of course all of these adults had a fasting plasma glucose in the non-diabetes range at recruitment. And they got lifestyle modification plus placebo, orlistat, or one of 4 doses of liraglutide up front. And then in the second year, the folks who were on orlistat kept doing that, and the other groups all were able to switch to the liraglutide 3 milligram dose. So the orlistat is the green line here, so you can see where that is. And then the dark blue is the 3 milligram liraglutide dose, which is, of course, the one that we use, so you can tell that has a better impact. So they were treated initially, there's the 20-week mark, and then the 1-year mark, and followed up to the second year. So the mean weight loss over 2 years for those who were in that group was about 10 kilograms, which is pretty good. And this actually is if they were able to maintain that. So the individuals who had lost at least 5% of their body weight at year 1 that maintained it at year 2 was 70%. And of the ones who had lost 10% of their body weight at year 1 who were able to maintain that at year 2, it's 48%. And these are, year 2 is the combined group of everybody who was switched over to the liraglutide dose that was pooled in that. Believe it or not, we have 2-year data for the GLP-1 analog in kids too, so, or nearly. So the study that they used to get that approved was 125 youth. They were treated for 56 weeks and then had a 56-week follow-up. And, no, these are individuals without diabetes because this was a weight loss trial. And I'm sorry I covered this up and didn't intend to, but this essentially, they all regained weight. You can kind of see it's upsloping under that blue box. But when you stopped liraglutide at 56 weeks, they did have a significant weight regain. However, their weight change was 4.5 kilos, which is pretty good. Okay, so I told you we would come back to this chart. And what I wanted to do was look at how much weight do you need to lose to have a meaningful impact on blood pressure, cholesterol, obstructive sleep apnea, and did any studies actually meet that? And with diet and exercise, metformin and GLP-1 analogs, you were able to meet that in about half of the participants after multiple years, 2 to 15 years in that to impact blood pressure, which is pretty good. Cholesterol, it was about the same. And then that obstructive sleep apnea, that study had to meet the 10% weight loss threshold. So it was a lower percentage, but still around 30% of individuals in those trials would have a meaningful clinical impact, which is, I think, important. The data isn't as clean for the pediatric studies since we don't have nearly as many, but still the potential to have a meaningful clinical impact on these outcomes that we're really trying to improve. There is a disconnect sometimes between weight loss for clinical outcomes and weight loss for cosmetic outcomes. So sometimes that may impact the ability or the desire of patients to kind of stick with these modifications. But from a clinical outcome standpoint, it seems like these things are impactful. All right, so we found positive impact lifestyle modifications that were long-term and medications that were used long-term, which I think is good. And something that we need to consider from a pediatric standpoint is looking at can we get kids to stick with lifestyle modification long-term? The only study that's really tried to do that was the Today study, and they did look at that and just to see how many kids could stick with it. And it really depended a lot on the parental engagement. They didn't really have good weight outcomes from that, so I didn't include it here, but they did measure the parental engagement, which is a challenge we have in pediatrics that's a little bit different, I think. But we also need to look at more novel approaches to maintain weight loss, and maybe that needs to be a bigger focus in the work that's being done. And the studies really need to go on beyond that 2-year mark, at least to the 2-year mark, but beyond. There really aren't good long-term studies in pediatrics quite yet. And then, of course, I think we'll have much better outcomes if we really look deeper at the physiology and the biologic adaptations to weight loss and try and tailor our approaches around those. So the majority of medications we use in pediatrics are used off-label. About 70%, give or take, right? And so the weight loss medications and the really expensive medications, we don't have the same opportunity to use off-label. But the Best Pharmaceuticals for Children Act Act is the FDA's way to try and encourage companies to do the studies in pediatric populations for different medications. And obesity is on the list for adolescent research priorities that came out in their most recent publication. So hopefully we'll be able to move the needle on those opportunities in the coming years. All right, so are there any questions? Okay.
Sorry, I came a few minutes.
Oh, no.
So that was a great thing. Most of the obesity issues we deal with in the adult all started in their childhood and many times perhaps in the utero, through the maternal. Mm-hmm. So a couple of questions I had was related to how BMI percentile and body mass, like the distribution. So when these kids are in physical activity and they're knowing the bone weight, the muscle weight, the child, male, female, child, people go to the people. Is there BMI right? So you take waist circumference or other details that you look at. So how do you kind of explain that?
That's right. So there is still some disagreement in the literature about if the waist-to-height ratio is a better predictor of cardiovascular outcomes in pediatrics. And there is some data showing that it is a better predictor of early onset high blood pressure, high cholesterol in like the early 30s for individuals that had obesity in childhood. But it's not easy to measure in the clinical setting. And so most of the individuals that do the vitals, they're not trained to do waist circumference. And so that's not something that's commonly measured. It's really just in the research realm. So there are limitations to BMI, but they are not really being addressed in new ways right now. I will tell you, nobody uses BMI Z-score anymore. We're down to BMI adjusted. There are some changes in the research world, but not in the clinical realm yet. BMI is just too easy.
So since Phentermine has been around for quite some time.
Yeah.
And a lot of adult literature where it has been used off-label for years.
Yes.
Is there an equivalent thing in children?
So yes, there is not a lot of off-label data, but I will tell you that it is being used off-label because it is accessible and other medications are not. I would love to know if you are looking at the term off-label, because I did find some data saying we have used it for so long, and yeah, we have these theoretical side effects, but we haven't had a big problem with that. And so if we're monitoring people closely, why not use it for a long time? And so I did find some of that in the literature, in the adult literature. In pediatrics, I could only find one study that had that was one center kind of reporting their experience. They did not report using just Phentermine, but they were using the Topamax plus Phentermine, which there's a pediatrics trial for that that's just finished. I'm sorry?
Phentermine 15.
So the pediatric, in pediatrics, we always mess with the doses. So the study that they just wrapped up in pediatrics, I can't remember if there were 2 or 3 doses for that, but it was definitely more than one. So they published the PK analysis from that, but not the overall results from that. But I think that it's going to be, if friends of mine have done it, I think it's going to be positive.
Phentermine long term. And also, one of the original medication studies, Tom Warden and they used it for 4 or 5 years.
Yes.
And they show a nice curve of how it can maintain weight loss. We're always afraid because, it is controlled substance, all of those things. So you have to keep writing every 3 months. You can't write it for a year, and so it's kind of a hassle. And you're always afraid that if somebody has a heart attack that they'll say it's because of the Phentermine,
Right.
So you're always concerned about it. But there are people who
Yes, but they haven't reported it in pediatrics yet.
So the thing is that one of the things is, even though you have some of these changes that you show, you drop in blood pressure, drop in
triglycerides are really small,
Yes.
but I assume that a lot of these children are not hypertensive or hypertriglyceridemia. Because it's usually in the adult world, we are looking at the hypertensive patient, and then you get a much bigger drop, because the higher your baseline, the more the drop that you're going to get.
Absolutely. And that's a really good point, because even in the study for Saxenda that got that FDA approved in pediatrics in December, the weight loss was not incredibly large. But one of the discussion points was, is it a realistic outcome that they stopped gaining weight? So is the lack of weight gain something that we should really consider as a positive if we're able to, use it for weight maintenance, which is a big deal. So definitely a fair consideration for the outcomes in kids. Yeah.
And the cost is the big cost of adults too.
Yes. Yeah, it costs the same for them, right?
Yeah. So difficult to get.
Right. But, I did find at least one statement in the adult literature, and I don't remember, it was from one of the societies, saying we really should use these drugs long term. And so I wondered if that's something that you all see a lot, is using them for more than 5 or 10 years.
For the Phentermine?
For any of these things,
Well,
they
are approved. We can use it. It is really the cost that makes people
not be able to stay on it.
Like at least $200 out of pocket.
Right.
Per month, and that's not something.
Yeah. That's right. Short term, right? So then we're stuck with, okay, we get that jump start on loss, which all of them show you regain weight as soon as you stop the intervention. So we need a follow-on intervention. It's going to help them make
the best evidence that the weight loss medication works.
Mm-hmm.
Because it's not,
Yes, that's right. It did something.
It was doing something. That's why you regained.
Yeah. And especially, I remember Dr. One of those real life pragmatic, because the weight loss studies are usually with the dietitian. Shows that kind of not having all those other options, he was still able to, but then still can't afford those things.
That's right. The other thing I think that is interesting about how they do the trials with the weight loss medications is they typically say, as part of the protocol, that the lifestyle intervention is per your center's standard care. So whatever your lifestyle intervention is, which is not very standardized across. Now, something like the Today study that was modeled on the DPP, it was a huge amount of time and effort to administer that lifestyle program, and so I think that's part of why they just have you do your center's standard, but it does impact the results, I think.
But I think, the use of weight loss medications has remained very low all along. Even now it is very low. And in addition to the cost, there's a lot of skepticism about it. The initial ones had their problems. There were side effects which were kind of hidden and people didn't accept it. And now we have, and I think one of the biggest problems, in addition to the cost, is the weight loss expectation.
Yes.
Especially in adults, they want to lose 100 pounds. So a 20-pound weight loss is not acceptable. They'll stop the medication and gain 30 pounds. But they will not take it because it didn't get them to 100 pounds less. 250 pounds, they want to be 140.
Right.
So that's been one of the biggest problems, and they'll be disappointed with even 2-pound weight gain in between, and they'll. So that's why it requires a lot of effort in terms of explaining to them what can happen.
It's true. It's a balance of those expectations up front and the focus on the impact on health. And, when we're focused on impacting preventatively, right? Like you don't have hypertension yet, let's prevent that. And then, kind of the absence of a disease that you never had is even a harder sell, I think.
So are there longitudinal studies, and I assume it's only been like Sweden or Switzerland or something like that, of weight loss efforts starting in childhood whether there are mortality outcomes or, you know,
So there are long-term weight studies. So especially with there's the biggest ones are the British birth cohorts. So there was a Boston birth cohort and a couple of other ones that followed the development of disease over time. So that's how we know that, that higher BMI in childhood or even the higher birth weights or SGA babies have a higher risk of early onset hypertension and other things. That's right. And so, however, the things that have been published so far don't look at weight change, like the kiddos who were obese and then lost weight and then what happened in the long term. So I couldn't find anything along those lines. But
it was like in the VCCT, early intervention had some sort of a memory effect. 20 years down the road, we're having, even though now they're not that well controlled,
right,
they're still getting better outcomes.
Yeah.
So whether there is such an effect, fine. Yeah.
Right.
There may be questions in the
Does there?
Off of the
unshare your screen.
Thank you. Thank you. Right, for weight loss in pediatric overweight patients. So, I did not find any studies on the intermittent fasting in children. I would imagine that we wouldn't try it before adolescence, but I did not find anything like that. I will say that we don't typically use metformin for weight loss in pediatrics. The only studies that we have, you lose weight early on and then everybody regains it by a year. And so we don't have any studies using metformin long-term like they did in the DPP trial in kids, so we don't use it for weight loss, and we typically only use it if they have prediabetes. But we have seen so much weight gain because of COVID. So as far as the kiddos with the kids that have ended up very sick in the hospital with COVID are limited compared to adults. I have not seen anything reported about significant weight loss. I will say that I've talked with the individuals who are running the long-term follow-up clinic for kids who have had COVID. A lot of them end up with that MISC. And so they have cardiovascular, cardiac really issues. And then there are kids that have had mild infection that are being seen for fatigue and things like that, but they have not reported significant weight change on those. Did the kids with overweight show any compared to healthy ones? I didn't look at, as far as the question about kids with overweight with cardiovascular complications to healthy ones, the answer is yes. We definitely know that the individuals who are overweight have increased risk for early onset of high blood pressure, high cholesterol, type 2 diabetes compared to healthy weight individuals. And then I did present a lot of what we know in pediatric studies about if weight change, how weight improved the outcomes. Do high triglyceride levels correspond to obesity? If yes, why not try to reduce triglyceride levels? Absolutely. Okay. I think that's all of are there any other questions? Yeah.
Well, yeah, Sarah. Steve Witter's here.
Oh, hey, how are you?
How are you? Well, first
thanks.
a comment. So obviously there were reproductive consequences of adolescent obesity. One, of course, is the development of PCOS and lifelong infertility. Yeah. And in Bale's literature that we contributed to, there appears to be a decline in inhibin B levels, which occurs during adolescence. And there's a whole thing about lower sperm counts now than there were 50 years ago, which some people have ascribed to environmental pollutants. What we proposed was due to insulin resistance and obesity, and there's certainly an ongoing debate about why the sperm count is going down. And I think that looking at reproductive outcomes in some of your proposed studies would maybe be a worthwhile thing to consider. And also, one other question, and that is, have any of the studies looked at muscle mass? My understanding is that when people go on extreme diets and lose weight, not only does the fat mass go down, but the muscle mass goes down. So I wonder whether you've used bioelectrical impedance or other endpoints to track where exactly the fat is lost. Is it sub-Q fat? Is it visceral fat? Or is it muscle?
Yeah, that's a great question. So I didn't look for those studies. Those would have been a shorter term study to look at that analysis. So I did not search for that. But now I'm intrigued. I'm going to have to go and look at it. I would imagine it has been done. I found a really interesting study talking about tongue fat and weight loss decreasing tongue fat, which is probably how we're improving obstructive sleep apnea with weight loss, but I didn't know we measured tongue fat. So I would imagine it's been looked at, but I don't know the answer. And thank you for your comments on the reproductive health. We don't have any long-term studies looking at PCOS in kids. It's hard to look at that over the long term because until 7 or 8 years ago, we didn't even have a pediatric specific diagnostic criteria for PCOS. And, it is, as you know, there are multiple different criteria, and we just kind of adopted those to kids. And so the diagnosis was less consistent. But we do now. So I think that would be a good thing to look at. Yeah. All right.
Thank you.
Well, thank you, everybody. Have a great day. Oh, no.